Jack's a 58-year-old who has this shoulder. This x-ray shows you that he has fairly significant osteophyte formation, but also bone-on-bone osteoarthritis within the shoulder. Now fortunately, we also have an MRI for him that shows his rotator cuff is intact, and that's going to be very important for our treatment. Here's his axillary view, which means looking up from his armpit, and again we'll see bone-on-bone with both osteophytes in the back and osteophytes in the front. Osteophytes, of course, are bone spurs. And looking at one additional view here from the front with his arm rotated up and out, again we can see that he clears his rotator cuff attachment zone from the overlying bony structures, but he has a large portion of the joint which is essentially bone-on-bone right here. It almost certainly originates from the fact that he's been a fairly heavy weightlifter over a number of years, seeking fitness through resistance training, and apparently has worn off his articular surface there. Okay, so the first thing we're going to do, of course, is initiate our anesthesia, because Jack would probably like if we would do this procedure with anesthesia. So what I've done is I've triangulated my entry point here such that my subcutaneous area will be longer than, big stick, Jack, so the subcutaneous area will be longer than the lead portion of the fat aspiration cannula, which I'll demonstrate in just a few moments. Now, first thing I'm going to do after the local anesthesia is kind of set in place there is just paint the area to begin the bactericidal action. Okay, so now we're going to begin using the local anesthesia for the area, and the markings that I made before correspond with using this 6-inch needle all the way across the belly. It's 15 centimeters. And the whole point of this is to anesthetize the entire area that's previously marked, such that it's called tumescent anesthesia, so that during the course of the extraction of the fat material, we don't hurt our patient. So we're going to go through the previously anesthetized area, which hopefully he will barely feel. And as we pierce the skin here, we're going to run across the subcutaneous layer through the fat layer, which fortunately is relatively devoid of nerve endings. So I'm sure that Jack's feeling this, but probably not as much as he expected to. And you'll see that what we did when we did the anesthesia preparation, you can see we make sure we anesthetize it longer than our needle will go in even with pressure. So you don't have to worry about getting out of the anesthetic zone, and I'm sure that's very comforting to Jack here. Can I have a 15 blade right there?
Yes, blade.
And this is the tip of this blade is all the width that we will need for the purpose of doing our entire procedure. Hopefully you won't feel this, but a little stab wound. Tough skin. You've been told that before, right? And that little opening is going to be all that we're going to need here. But not for him anymore. So I'm going to pass this right across. If I'm hurting you, say something. Don't forget to break the skin. I'm going to pass this right across in the subcutaneous layer. And if he's well anesthetized, he'll feel what I'm doing, but it shouldn't be hurting him. Is that accurate?
That's correct.
And then by moving back and forth, we're going to start to procure some of that subcutaneous fat. We're going to do it in layers. I'm going to start near the surface to begin with. Get the most difficult to procure fat, which is also the densest, right up underneath the skin. Coming out here is that's been our last pull. You'll hear it break the suction. So that's the last hole there, and you see that's, so as long as I was concentrating on working in that zone, that was longer than our suction opening from the tip of the tube. And that's pretty important if you don't want to be involved in going in and out on several occasions. I'm going to hand this off to you, and we're all good. Master. To draw out more of the specimen than we can possibly use for a shoulder. So we have 11 cc's right there, and we won't use more than 5 or 6 cc's. You can see it's going to be the best fat quality right there. As we can see it coming in the bottom of the sulcus there. So I'm happy with that positioning. And maybe I'll get some fluid back out, which is often asked for confirmation. Yep, get a little bit of it back. Let's go a little PRP. And then we'll go to the fat and then go right back to PRP. Okay, so we put in a little bit of the platelet-rich plasma first to clear the needle and to begin to bathe the joint surface. And I'm ready for the fat now. I would not be surprised to see some of this beginning to leak back out, because it does that on occasion, as you can see. Thank you. That's the reason I only put in a cc or 2 to begin with. And now, put some of the fat graft in there. So I'm starting with the plunger at 11. So I'm dropping the plunger down to about 5 or 6. Which fills the joint pretty nicely. Probably beginning to feel pretty tight, isn't it? Mm-hmm. And the fat doesn't usually come out just because it's kind of a plug. Sorry about that. Put some of your fat on your bib there. I'm going to fill the joint with the rest of the PRP now. And by now it's probably feeling pretty tight. And that's the entirety of the procedure.